I'm not a HRT doctor. I'm a midlife doctor.
What age can we consider ourselves midlife?
If we look at it reproductively, I think midlife is when our reproduction starts to dysregulate a little bit.
There's such an important link between strong muscles and brain.
So did you know if you have good muscle power in your 50s, you're less likely to have dementia in your 70s? So what can we do? We need to do strength training.
I'd love to talk to you about bone health.
If your bones are low in bone density because you've lost estrogen, then putting estrogen back in is going to improve the bone density. But if you've had normal estrogen levels, I want to pick your brain after it, actually.
Okay.
Because I've been talking to Tanya Mulcahy. Remember, she was at the meeting.
Yeah.
And we want to start collecting the evidence, but we want to know what the question is we're asking.
Okay.
So I need you to think about that.
I will, absolutely. And in there not being the evidence, that's the issue. Who's going to do the research? Because where is the money going to come from? Because you're not going to get pharma to do more research on estrogen because they can't patent estrogen.
So we want to look at, like, how, we keep saying you can't check the levels, but there must be some way.
Yeah.
So do we, like, kind of start looking at capillary blood versus, you know, how can a woman collect it every day?
I know.
And show us, like, and you know, there's that Dutch test, but does that compare to, like, maybe a finger prick? You know, if you can wear a continuous glucose monitor, could there be a day where you could wear a continuous estradiol
well, someone
monitor?
said to me that, like,
for
why isn't there
because it's so complicated biochemically.
Yeah.
And Tanya's a biochemist.
Yes. But it's also that that part of what the bugbear is. I know that there's no research in the dementia side, but like Dr. Lisa Mosconi is doing a lot of that.
Yeah.
But it's where's the funding going to come from? Because if a pharma company can't patent a drug, so we know estrogen is freely available, you can buy it. But unless pharma can profit off it, they're not going to put the R&D into it. So where is the research going to come for women? Longitudinal studies when it comes to estrogen.
Yeah.
That's the issue, isn't it? Like, that's the crux of it.
And maybe, like, government funding.
Well, this is it. Does it have to be government, worldwide, global?
And like, my question is around perimenopause, because, you know, putting a patch on it, pardon the pun, but, like, we still have estrogen. It's fluctuating.
Yeah.
How can we check what it is from day to day?
100%.
And if you knew, would you need a different dose today than you did tomorrow? And particularly, would you need a different dose in the luteal phase?
Yeah.
And how do we balance that? And we keep saying, oh, it's just too hard to measure, but we've got to work that out.
I have women in the pharmacy, though, they say that they, like, 2 or 3 come into me and they say they wake up in the morning and they know by the way they feel when they wake up whether they need 1 or 2 pumps of the estrogen.
Yeah, and which is, I think, why some women are doing well on the Linzetto spray. Yeah. However, are we doing the right thing in the long run to have fluctuating levels? Is it actually, because what we're trying to do is get on top of that.
Yeah. Those
peaks and troughs, like, to try and level it off.
Yeah.
So when they say, but there are times when I think, particularly when the period is about to come and they get really symptomatic, that sometimes an extra spray of Linzetto can be effective. So, like, we have to know more. Yeah. We can't keep saying, oh, look, we've no way of measuring.
And we've no research on, like, let's just leave it.
Looking at how we can collect that.
Yeah.
But it's, like, a biochemical conundrum.
It is.
Yeah, yeah. So where do we start? But someone has to start, Laura.
Maybe I should start it.
Yeah.
I do think there's such a dearth of information. And
we have women, we're at the forefront, we're meeting these women every day.
And I know so many that have no issues going into some kind of a study where they could get this done.
So I met this really interesting Irish girl in Melbourne who has just finished a PhD in Dunedin in New Zealand because she just got tired. She was UCD science and then she just wanted to go somewhere different. So she went to New Zealand and she's done a PhD on the different estrogens and estrogen receptors in the brain, which I think is really interesting. So she's really interested in knowing, is estradiol what the brain needs or is it some other estrogen? So she's interested in carrying that on, like, postdoc. So we might need to kind of catch her again and say, what question are you asking?
Absolutely. Yeah. So many people.
So the brain health is something I'm really interested in, actually.
It's one of
that space.
Yeah, no, I'm trying to keep on top of that too, but it's hard to get that info though as well.
So what I'm now excited about is the link between the muscle and the brain.
And we're going to talk all about that now.
Yeah.
So I'm going to count us in.
Okay.
Okay, everyone, welcome back to the show. Today I'm honoured to have Dr. Clare Cromwell join us. Clare is an accredited advanced menopause specialist and general practitioner based in Cork City in Ireland. Dr. Cromwell graduated from University College Dublin Medical School in 2003, and she is a member of the Irish College of General Practitioners and holds the DRCOG diploma from the Royal College of Obstetrics and Gynecology. With a keen interest in women's health, she operates a dedicated menopause clinic within the Mater private network in Cork and works in the Department of Gynecology at Cork University Maternity Hospital. Dr. Cromwell is passionate about educating both medical colleagues and patients in all areas of women's health. Clare, it's such a pleasure to get you up from the real Republic, isn't that right?
Well, I'm not from the real Republic, Laura. I'm just home today.
Okay. Up for a rugby match?
Yes.
It's great to have you. And you and I did a webinar a few months ago, and I thought I need to get that lady on my podcast because you were talking all about midlife health.
Yes, I think
and
we connected there.
Longevity and muscle health and brain health. So I actually think I could sit back and just let you talk.
Oh God, don't let that.
So just tell me a little bit about the passion that you have in the women's health space and why it's so important for you.
Well, I suppose I always open with the fact that I am a GP. And I am still a GP, and I think that's really important in midlife health. So I'm passionate about menopause, and I do provide a menopause specialist service, but I also work 1 day a week now as a general practitioner. And I think that that kind of is really important to the entire menopause consultation, because it's not just about the menopause, but it's about what else happens around that. It's about family life. It's about everything. So I think that just puts a perspective on the fact that you sometimes to take off your menopause hat and put on your GP hat and make sure you're not missing anything else that could be contributing. But I suppose as a young female GP, I had a lot of antenatal patients. My patients were getting pregnant and they were having their babies. Then they were postnatal. And then I was no longer a young female GP. I was just a female GP. And the same patients were developing really interesting but like different dilemmas, and a lot of it was cyclical, a lot of it was around their hormones, and it just really sparked my interest to know what else is going on. I graduated as a GP, graduated in 2003. I qualified as a GP in 2010, and somewhere between 2003 and 2010, the world of menopause and HRT really changed. And during my GP training, like the word was mentioned, the concept came up, and really the message was just shut it down. You know, don't prescribe HRT. We didn't really get any more help beyond that. And I didn't really think about it. And to be fair, they probably weren't the patients who were presenting to me at the time. But so I just felt a gap in my knowledge, and I thought I need to know more. I don't like gaps. So I really started looking at menopause health more. And then, as you can imagine, in the last few years, GP world has ramped up. So even though you'd love to fill the gaps in your knowledge, there's not a lot of time. And it was between COVID and there was such a demand on time for practice, I was finding that it was really difficult to even find the time to read extra. So in the end, I decided this is what I really am interested in. So I stopped for a while, continued with my general gynae half day a week where I do gynae outpatients, and I stopped my general practice for a year and I did my advanced menopause specialist training with the British Menopause Society, and then I came back. But having said that, you could stop and you could read forever, but until you see patients and you hear women speaking, you can't really put that into practice. And really, the combination of the two is what you need to understand midlife health.
And what are you seeing and what are you hearing? You're just back from Australia, and you said there's such an important link between muscles, strong muscles, and brain. So I would love to delve into that with you.
And that's quite exciting. But I suppose mainly that I'm not a HRT doctor. I'm a midlife doctor. So I find that even though a lot of women, by the time they present to me, they're struggling to understand what's happening, what's changing within them. I find that as opportunistic, like a real opportunity to sit down and look at what your life is now, what your health is now, but also what your future health is and could be. And I think that maybe in times past we think like, oh yeah, like there's genes in my family for heart disease, so I'm probably going to develop heart disease. But it's empowering to know, no, you're not. You may have inherited a gene for high cholesterol, but your epigenetics are how the world and the environment and what you do influences those genes, and that we have far more power than we think to change the trajectory of where those genes will go. So getting kind of sidetracked, but regarding muscle health, there was a fantastic talk in Melbourne, a guy called Professor Robbie Daly, and his whole career has been focused on looking at muscle and the connection of muscle to the brain, and how midlife muscle matters was his message.
Can you just explain to the listeners what midlife means actually? What age can we consider ourselves midlife?
Yeah.
Because sometimes, I remember like even just a few years ago, I would have thought, there's no way I'm middle-aged. But at 44 I am.
Like, God, I don't know the actual definition of midlife. I would consider, I suppose, if we look at it reproductively and look at our reproductive cycle, I think midlife is when our reproduction starts to dysregulate a little bit. Mm-hmm. So when we look at perimenopause, like the change from premenopause to perimenopause, I think it's when we begin to feel the dysregulation of hormones. So you could still have a regular period, but you're still starting to feel that dip in estrogen that's coming at the end of your cycle, and you might be more sensitive to the surge in estrogen that comes before that. So when you have that surge of estrogen, you might feel like the sore boobs, feel a little bit different. You might actually be in great form, but you feel some physical symptoms. And then the drops in estrogen are those kind of perimenopausal symptoms that we mentioned. Can be physical, can be psychological, and can be definitely in hindsight going, oh my God, actually, I've been feeling that for a few years. So I think midlife kicks off when we start to notice those changes, and then we can notice a change in our periods, but that can actually come later. Sometimes our periods actually become a little more close together. So you might have always had a 28-day cycle and suddenly you've 24, 25, just a subtle change like that. They might get a bit heavier. And then as we get later into late perimenopause, where the periods tend to stretch, or you might start to skip a few cycles. And that's before that D-Day that we call menopause, which 12 months later we'll know you've had no periods now for 12 months and you're officially menopausal or post-menopausal, as we describe it. So it's all a transition. So I think midlife is the beginning of that transition, really. Mm-hmm.
Okay, that's important. Yeah, people know that.
Yeah, so that's why midlife muscle matters.
I like that. Might steal that line.
I like that too, because we're so focused on bone, which we should be, and we know that when we start to lose estrogen and our ovaries no longer make estrogen, that our bone density will naturally decrease, and it is a natural decrease. But if we have another risk factor, or we've inherited a gene, we might have an accelerated decrease in that density. But looking after our bones includes looking after our muscles, because ultimately, if you are more likely to break a bone if you fall, but you are fit and you have good balance and you have good muscle, then you're less likely to fall. Realistically, You're more likely to right yourself. So therefore, when we're looking at preventing fracture, we can't ignore the muscle. So this guy has done a lot of research into how we maintain midlife muscle. And for actually, he was looking at postmenopausal women as well. So we do lose a significant amount of muscle with each year postmenopausally. I think it's like maybe 3% per year, and can be significant. And if anything stops us in our tracks, say like you've take to the bed for some other reason, or you're sick for a while, there's a massive decrease in muscle really quickly in more elderly people. So if they're admitted to hospital for a week, they can have up to a 10% loss of muscle in that week. And it's so much harder to rebuild muscle than to maintain muscle. And that's why it's so important. So what can we do? We need to do strength training. And that was the message I took home. The one message was that anything is better than nothing. So moving and not being sedentary has now been added to the WHO kind of recommendations for movement and health, as opposed to saying exercise. We're talking about mobility, so we need to move. But if you're looking at how you can maintain your muscle, he was recommending at least 2 strength sessions per week. And what he said is you don't have to go to the CrossFit box and lift as heavy as you can and keep working up on heavier weights. But he said you need to feel it, but it doesn't have to be really heavy. But it's the reps can matter as well. So I thought what was a good recommendation, which anyone can really follow, is to work on your upper body and your lower body, to do about 3 exercises that works on your arms and 3 exercises that works on your legs if you're in a session. And
your legs include your glutes as well, because they are the biggest muscle that you have in your body. It's your bum, basically.
Exactly.
And it's so important for getting up out of a chair, sitting down into your chair.
Or righting yourself quickly when the bus moves off or the tram moves off. And what he said was your muscle power really protects your bones. Because if you're standing beside an elderly person on the bus and it suddenly pulls off, your muscle power is what powers in your glutes and your hamstrings to stop suddenly. So it's that quick reaction. That doesn't matter how heavy you're lifting. It matters like how many reps you're doing and how much power is left in the muscle. So he was saying 3 upper exercises, 3 lower exercises, and about 15 reps and 3 sets.
Okay.
Does that make sense?
Yeah.
So for straightforward, that kind of makes sense to me. If I go to the gym, I want to do 3 on my upper body, 3 on my lower body.
3 sets of each and about 15 reps.
Yeah. And then he said he said if you're coming out of the gym and you felt exactly like you felt going into the gym, you've probably fooled yourself a bit. You need to feel something, but you don't have to be dripping with sweat.
No.
So it's not necessarily that, but he did mention that adding in some cardiovascular exercise for your longevity matters as well. So whether you get your long walk in, like women will often come to me and they walk and they love to walk and the dog needs them to walk. I would never tell someone to stop walking.
Yeah.
But if you've only got a limited amount of time and you're putting it all into walking, maybe, and what I often say, Laura, as well, is and all over Cork anyway, we've beautiful walks along the river. And there, those machines that the kids are always playing on?
Yeah.
And there's no adults on? It's stop. 10 minutes. Just do some movement exercises, do some resistance exercises. And they can really matter.
That's important too. And it's important that people don't necessarily, that they know they don't necessarily have to buy a gym membership. If you have a couple of dumbbells at home, like I have a set of dumbbells, and you don't need to have from, 5 kg all the way up to 25 kg. If you have a 3 kg, a 5 kg and an 8 kg, you can do so much.
Exactly. And I suppose the question is the motivation to keep going there at home. I'll definitely easier on myself at home than I am in a class, or if you've never done it, you need to learn how to do it properly. So even one session, or to check in with a physiotherapist maybe, and they could give you, work out something, your homework that would work for you. I think sometimes it's a struggle that people just hate the gym, or they can't afford to join the gym.
Yeah.
So there is always a solution.
Yeah.
And I think those exercise things along the path, when you're out for your walk are good too.
And there's also YouTube videos as well for free that people can access. But what I would say to people as well is to make sure that you are looking at someone, or in the gym asking for someone who knows how to deal with midlife women in particular, because you do not need to be lifting big heavy weights that might aggravate a prolapse or hurt yourself.
And if somebody is advising you something that doesn't feel right for you, then they're probably not clued in to midlife. But thankfully, I think, and a lot of the younger personal trainers and gym people now are more connected to the fact. And also, if you've got someone at the gym who's obsessed with you losing weight, then that's not my focus, and that never is. And I know that, and we're kind of moving into midlife weight gain, but that women always struggle with weight at this time, and very few women who come to see me are happy with their weight. But I try to take the focus off the number and say, if you stayed with the same number, but your body felt different and you felt strong, they want to be strong. And I think it's really important to feel strong, and you'll get a surge and a pump of energy from changing that fat to muscle as such. Mm-hmm. So I think automatically, if we're focused more on strength and muscle and just longevity and power in your body, that you'll instantly feel better about how you look.
Exactly. Yeah. And also if you are building muscle, that's helping with insulin resistance. It's helping with
completely
all of that.
Protein as well. He did emphasize protein. And I suppose if you do feel that you're in the category that you need to lose weight, that if you're losing weight by whatever means you're doing, but you're not exercising, you're not doing your body any favor because you're losing your muscle. It's really hard to lose fat and not lose muscle. So any women who are on kind of weight loss regimes, if the person supporting that is not insisting that you're working out, then it's not working for you. You're going to lose your muscle, and your muscle is the powerhouse of your body. It drives all of your machines, including your brain. So did you know if you have good muscle power in your 50s, you're less likely to have dementia in your 70s?
That's wonderful, isn't it?
Which is fascinating.
Yeah.
And it might be more of a driver for somebody to work out.
Absolutely. Should they say, there's Peter Attia says, the biggest tool you have in your toolkit to help prevent or to help reduce the instance of, say, Alzheimer, dementia, and those cognitive decline is exercise.
Yeah,
it's not even
absolutely.
the medicines.
Yeah,
it's the exercise.
Yeah, and which is like why, and there's something for everyone. Like there's something that everybody can do, and it's a free drug. It's just so important for everything. But to think that if you work on your muscle, you're indirectly working on your brain and your cognition, then I think that's a driver as well, isn't it, to get up?
100%, yeah.
So, I thought he was really interesting. And he did talk about protein as well and how our protein requirements do increase as we age in order to maintain the same amount of muscle, and that often if we're trying to lose weight we mightn't be getting in enough protein.
Do you know what the recommendations are there? Because I know that they vary, and you can Google all kinds of things, like 1 gram.
So what this guy was saying is like about 1.3. It definitely, once you become postmenopausal, you go above 1 gram per kilo of body weight. So about 1.3 to 1.5 was his recommendation.
But you're not going to be doing yourself any harm if you're taking 2 per kilogram.
He did say 1.3 to 1.5.
Okay. I love it.
I'm not precise because I find that overwhelming. And if you go into a gym and the trainer says, take 1.5 milligram or kilograms or grams of protein per kilogram per day, I'm like, that means nothing to me.
Yeah.
So to the average person, it doesn't if you're not like a gym guru. But I started looking at this, like, darn of salmon has about 15 grams, am I right?
Yeah.
2 eggs have 12. Lean chicken is really good. So I think, like, in conclusion, and he agreed that you can get that much protein from being plant-based, but you're probably going to need to take more calories from the plants to get the same amount of protein as your lean your lean meats or your fish.
Yeah.
So you'd want to eat a lot of eggs to get the equivalent of your piece of salmon or your piece of chicken for the same amount. So you kind of need to kind of focus and not be cutting out your protein as well. Yeah.
But even at that, so say you're, I'm 69 kilograms, and then if you're to, multiply that by 1.5, it does seem like an awful lot of protein.
Yeah, it does.
And to try and get that in, like you're just saying, like a darn of salmon is about 15 grams. Like, to get that into your everyday, it can be tough.
And sometimes elderly people need to supplement.
Yeah.
And I suppose that's why when that supplementation in the hospital setting is vital, that you're prescribing it when elderly people are in. I don't think I ever valued that as an intern on the wards, and I saw that a lot of them were on it and would go home on it, but how priceless that is to maintain muscle, to maintain their independence, once they get over their acute sickness. What lies beyond that and how much bone or muscle they've lost is phenomenal.
Yeah. And also because their appetite can naturally decrease as they get older too, so it could be much more difficult for them to get that protein in. Yeah. But the protein is so important, so it's whatever way you can get it in, I suppose, is
so
really
around
key.
Like kind of perimenopause and midlife, I think we can definitely do it naturally by our diet, but kind of sitting and watching, saying, am I having enough protein? But
I know I don't like the powdered stuff. It just doesn't taste.
No, and
taste nice.
he said whey protein is the more effective, but it doesn't taste good.
No. Is it more effective than the kind of the bovine one?
He said it's the most effective to build muscle quickly, but that the problem is the taste of it and that a lot of people don't like it. And then what he said was that the veggie-based ones are effective, but that you probably need to take more of them to build the same. Yeah, so I think if you're at that stage, you need to supplement. You probably need some dietitian advice there.
Yeah.
Even again, a once off, you don't need like a regular appointment, but if you need to build muscle and it's not happening, some decent dietary advice I think is useful.
Did he tell you anything more about the brain and muscle?
Yeah, so as I was saying, he said like I thought it was fascinating, the connection. The few things that I picked up was that your muscle power in your 50s can indicate better cognition in your 70s. So that's fascinating. There are also studies to show that sarcopenia in midlife, sarcopenia being the loss of muscle, measured by grip strength, which is really easy to measure. And I always forget the name of the tool, that the one you squeeze your hand.
Oh goodness, I bought one as well because I was doing a demo on it. Is it?
It definitely ends in
odometer or something, isn't it?
Yeah, monomometer. But it's, I'll have to think of it. But by measuring something as simple as as going to kill me when you find it now, as your grip strength can indicate a higher risk of developing depression actually in late life as well. Yeah, so I think that's
dynamometer.
Yes.
Yes. Okay, we have it.
Yeah. So using your dynamometer,
it's a bit of a.
But what's interesting about that is like, how easy would that be to do in a GP practice? Check your blood pressure, squeeze the dynamometer.
Yeah.
Easier to squeeze than say. But that, it would be quite an easy study, to pick up that if you might alert, and it might alert then, is the depression connected to lower cognition. And another interesting study that reminds me of is a group in UCSF, and they're actually going to talk in our next webinar in January. And a guy there who works in neuroscience called Professor Joaquin Angera, he has done a study in depression in older people, over 65, and he divided them into two groups, and he treated one group with regular antidepressants, and then the other group were treated with an app that he's developed, like a computer game as such. And it's actually like, one of those games where you're driving and you have to avoid kind of things that pop up in front of you. So kind of reaction time. And his basis is kinesiology, so the connection between the muscle and the brain. But the app, both groups, the depression improved. But in the app, the depression improved and the cognition improved. Okay. So that in some way, the connection and the muscle there was connected to improved cognition. So that's really interesting, kind of the use of technology in the future.
And then in terms of, say, estrogen and its effects on the brain and its effects on cognition, there just isn't a huge body of research.
There's plenty happening.
Yeah.
Yeah. But unfortunately, as I say all day, every day, we just don't have the evidence, which is very frustrating in the menopause world. But actually, even more frustrating in the brain health world is that the evidence we have is actually negative. But it's on 20 years old on combined equine estrogens and androgenic progesterone. So it's not what we use.
So the equine estrogen is horses, mares, urine.
Yes, what was used back in the days of the bigger studies that were stopped back in 2003. So in that study, the average age of women who were recruited to that study was 64. So these women already had heart disease, a lot of them, and medical conditions. And they were started on oral, old-fashioned HRT that we don't use anymore. And in that group, in the older group, they actually ended up with more dementia and Alzheimer's. So that our conclusion there was that starting HRT resulted in dementia. However, when they looked back 18 years later at the younger women in the same study, they didn't show the same results. And that what they showed was a decrease in death from dementia in that smaller group. And that's the only studies we really have today to quote to say, does HRT prevent dementia? We cannot say it does. So we need more evidence. But Lisa Mosconi in New York, they're looking currently, and I believe that they're looking at like MRI brains and showing that women who are on transdermal estrogen 17 beta estradiol, which is what we use now, that there's definitely decreased or the correct amount of white matter hyperintensities in these women compared to women who are not on HRT. So in some way suggesting that their brains look healthier. So that's step A. But we can't still conclude that HRT prevents dementia.
Until we do mass studies on it.
And I think the other thing that they have shown in New York at the moment, and the other person who's looking at it is Rebecca Thurston, and I think they've shown in women on transdermal HRT that they might have less of the plaque that ultimately, on the MRI, that ultimately results in Alzheimer's. So two quite exciting like preliminary results coming out of that.
But then I suppose it probably matters at what age in that woman's life she goes on that HRT, how long she's on it for. So there's so many
totally. And what
factors.
We're looking at is what is the window of opportunity. But there's another really interesting study by Emily Jacobs in the States, and what she has showed, she looked at women in perimenopause complaining of brain fog, and she saw that when she put them into a functional MRI machine, so gave them some brain training tasks while looking at their brain, that she could see with decreasing estradiol levels that there was a decreased blood flow to the hippocampus in the brain, like the processing center, the center for like executive function. So when she brought these women back at the age of 55. So regardless of whether they'd been treated with HRT or not, their hormones had plateaued. Instead of like, in perimenopause where the hormones are all over the place, suddenly there was a plateau of hormones and they were less kind of changeable. And subjectively, these women said they felt less foggy, and she was able to show objectively on the MRI that the blood flow had compensated to the other side of the hippocampus, and that the brain had the plasticity to fix itself. And I think that's a really reassuring study, because the biggest fear, if you come at 45 or 55 or 45 or 50 and say, like, I can't remember the name of the girl who sits across from me in the office every day. I'm looking at people and I can't remember their names. I can't remember why I came into the room for my keys. So it's really reassuring to say that is consistent with brain fog, but it looks like that's something different to early dementia, so
and
that
it rectifies itself. Your
if we
brain
did nothing, your brain
itself.
can fix itself. Yeah.
Because the brain fog lessens postmenopausally, women would say, or that
exactly.
Would, so it's
back
those,
on the game.
Exactly. So it's those fluctuating hormones that are probably causing that.
And which is the question, and I think is a really interesting question, is where is the window of opportunity for the brain? And hopefully there's some more research coming out to show that when is the right time to get the HRT started as such. Because right now we have a window of opportunity that we talk about for cardiovascular disease, and that is from your last period until 10 years after that. So that's, the golden moment that if we can, for the majority of women on HRT, from when their periods stop until 10 years after their last period, the benefits of taking it from a cardiovascular point of view outweigh the risks.
Yeah.
So that they get cardiovascular benefit from that.
But then after that 10 years is up, so the benefits outweigh the risk for that first 10 years. Yeah. Once the 10 years is up, is it advised that they just go off the HRT then? And then
like the reality is, on the day of your 60th birthday, you're like your heart has changed today.
Yeah.
Take off your patch, And it's totally unrealistic. And there's a big fear for women to say, and I think that there was an old fashioned rule of 5 years and you're off.
I know.
So what I always say to women is like that throughout your 50s, we're looking at benefit. When you get to 60, we don't have evidence of benefit. That doesn't mean there's no benefit. It means we've yet to prove that there's evidence of benefit, but there's no evidence of increased risk from a cardiovascular point of view. But what we're looking at is the overall risk. So you have aged and your risk of breast cancer is increased. in your 60s, you're more likely to get breast cancer than in your 50s. So it's back to the drawing board and see, because we don't have as much evidence now that it's benefiting you, do you still need it? If you need it, that's fine, we'll continue with it. But maybe you need less. And maybe we can tailor it back to as much as you need. So I just always work in, maybe say to a woman to work in 5-year slots to look and sit and calculate an individual risk-benefit ratio and see, these are your risks now, these are your benefits. What would you like to do next?
And that's so important, having that individualised care, isn't it?
Yeah, and that's why I think, HRT is not available over the counter, because it's so vital for that opportunistic moment to just address health, and like HRT, and that decision might be part of that decision at midlife, but also just the message about how much you can do for yourself. It's quite empowering, to think that you can influence your health span, and maybe have it match your lifespan.
Absolutely. Wouldn't it be wonderful if we could? What about the women, and there is a generation of them, or more than a generation, that feel that they missed out on the HRT train? Because I have hear women of 65 thinking, my bones, my heart, my cognition, my overall health, I never got the opportunity to take HRT. I pushed through it.
The boomers, aren't they?
The boomers.
Yeah, and I'm finding some of them are reading and listening and learning and presenting and saying, what about me? And again, it's a very individualized decision. We have evidence that HRT helps bone at any age. And it doesn't have to be in high dose either. But particularly if women still have symptoms of menopause, HRT is licensed for treatment of the symptoms of menopause. So especially if there's vasomotor symptoms, meaning hot flushes, night sweats, kind of intolerance of heat or cold still, then a trial of HRT is certainly on the cards. And again, we would look at an individual woman and see what other risks she has, what other medical conditions she has, and a perfect opportunity to look and see what else we can change. So I'd like somebody like that during the week, and you won't get out of my room without your blood pressure being checked, and you won't get out of my room with a prescription unless your blood pressure is normal. And that doesn't mean that you can't have HRT if you have a bit of high blood pressure. It means that that's the perfect opportunity to fix the blood pressure. So let's just kind of work together and look at all risk factors. And blood pressure is one of those really determinant factors in how long you live, how healthy your brain will be, and how healthy your heart will be. So that is something that's vital not to ignore. And our blood pressure could be up for a long time and we wouldn't know.
Yeah, it's known as a silent disease as well.
Exactly,
so if anyone is listening today, the best thing you could do for your health is actually just
check your blood pressure.
You
and
can
probably not with the doctor, because we have a tendency to put it up. But I find maybe sometimes with the pharmacist.
You can go into your pharmacies and get them done, or else you can buy these blood pressure monitors online as well.
And I don't discourage that either. It doesn't have to be the fanciest one in the world. What I say now, Laura, is that I always encourage, have you seen the Breast Aware app from Breast Cancer Ireland?
Yes.
Love it. So I encourage women, they download it in my room, because if you say, I'll download that later, it probably won't happen. And you set a monthly reminder on that. So for the rest of your life, it will beep once a month and say, today's the day to check your breasts. But have that as your blood pressure day too. So breasts and blood pressure once a month for the rest of your life, and just know your number. And then you'll notice a change in pattern. And I was actually reading an article by Dr. Paddy Barrett, who does a lot of cardiology.
I had him on as well.
Yeah, and he, just this morning, it was like a snippet on blood pressure, and that the number matters. So, we say, anything over 140 is abnormal, anything over 90 on the bottom. But 120 is better than 140. So if you're consistently in the 130s, especially if you're already on blood pressure treatment, you're not treating to target. And you need to talk about maybe upping your blood pressure treatment, definitely taking it. Before I increase it, I check that you're taking it. But yeah, the number matters. And looking at, I think anyone who's on blood pressure treatment or has been told that the blood pressure is borderline, they don't need treatment, they should be having a 24-hour blood pressure monitor once a year. Because your nighttime blood pressure is really important too. Are you a dipper? And there's evidence to say that people who have nighttime dipping, where your blood pressure dips about 10% below what it is in the daytime, that that increases your longevity, so that you're better off with the nighttime dipping rather than getting it. Like it's still important to be low during the day, but a lack of dipping is a real red flag for cardiovascular health. Yeah. So are you a dipper?
Are you a dipper? Yeah. I love that.
So that's where you can't do anything else except your 24-hour blood pressure monitor, which kind of moves on to sleep then, because if you're not sleeping, you're not dipping.
What a segue into sleep. Yeah, my favourite topic. Go.
There was a great talk in Melbourne on sleep. A sleep specialist. She was fabulous. But first of all, one interesting thing I found is she said when they look back into medieval times and they've tried to kind of do studies to see how people slept then, that sleep was diurnal. Is that the right word to describe it? People woke in the middle of the night and they often got up to check animals, maybe have a chat to their neighbours, maybe check on children, but that it was normal and natural to not sleep the whole way through the night, which I thought was interesting.
That's
interesting. Because now we expect if we wake up, there's something wrong with our sleep. But she said that has become culturally abnormal.
Just like babies waking during the night is considered to be, you know, something that's bad. You know, your baby's a good baby if they sleep during the night, which is absolutely not the case.
Yeah,
babies were designed to wake it up.
What age is he sleeping through the night?
I'm like, no, my baby didn't sleep tonight until they were 2, okay?
Yeah.
The end. And that's 2 years, not 2 months.
Yeah, I know. And to not like be beating yourself up, like you think you're doing something wrong when your baby wakes up. Like
your babies were designed to wake regularly and continuously, so you would constantly give them care and feed them.
And my memory was like changing there's something wrong and trying to spend days or weeks to try and work out what's wrong in the routine. And by the time you worked it out, there was a new problem.
I know.
Like back to but it distracted me throughout. Those cycles. But so like it mightn't be abnormal to wake up, and we have like different phases in our sleep, in our deep sleep and our REM, but what else I took from that was important is that not to presume that if a woman in her 40s or 50s comes in and says she's not sleeping, that it's perimenopause, you know? And often it is, but that sleep disorders and obstructive sleep apnea in women presents a bit differently. So there's a whole spectrum. And in men, it often presents with snoring and their partner either telling them or thumping them, you know, but to say that your breathing is really odd at night, you know, and you can pick up that pathognomonic where they snore, they snore, and then they suddenly stop, and then the brain kicks back in to start breathing again. But women can have disordered breathing without that obvious sign. Of course, like, you know, abnormal, as we call it, for 50% of the population, but that we can often miss obstructive sleep apnea. And particularly if weight is an issue and a woman is overweight, I think we should be looking more at sleep studies.
Okay.
So that's interesting that we, you know, especially if we can't fix the sleep.
And I think we're really good at saying you should be getting your sleep. Get your 8 hours sleep, and then women think there's something wrong with them when they're not. So they're lying awake at that 4 o'clock in the morning staring at the ceiling.
And here I am saying now it's so important to sleep so that your blood pressure drops. So if you're not asleep, then you're going, oh my God, my blood pressure's up now.
I know.
And she said the worst thing for poor sleep is to think about your poor sleep, because it's a vicious cycle. So what she really recommended was changing your mindset about sleep. So you could get 8 hours of sleep with a wake every hour and still cumulatively get enough sleep if you have enough time to accumulate that. Mm-hmm. But I suppose people are different sleepers as well. So you like, I know if I have a bad night's sleep, I'll sleep better the next night. Yeah. You know, you are tired that day, but I almost look forward to the fact that I know that the next night's going to be a good night's sleep.
Crawl into bed. Yeah, you know, you just when your head hits the pillow. Or you can go for a nap. I'm a massive fan of napping if people can switch off during the day.
Yeah, and I think there's a real benefit to 20 minutes is it in the afternoon.
Power nap.
Yeah.
You wake up feeling you've had a full night's sleep. I think sometimes
which is interesting. I worked with one GP trainer who always did that in the afternoon. But what she said was like, in order to change the mindset around sleep, and one of the most effective treatments for insomnia is CBTI, which is a specific type of CBT, and available online because it's not always, not that it's not effective with a therapist, it's really hard to find somebody to do CBT or to afford it. So there were a couple of websites that I'd love to share. Like an Australian one called This Way Up.
Okay.
And the other one she recommended was called Shut Eye.
And we'll put these in the show notes as well, actually, people.
Yeah, and I think they do the same as the Sleepio app that we did discuss at the conference in September. But Sleepio is not available in Ireland on the Irish App Store. I don't know why it's still not available. It's available on the NHS. So anyone who has an NHS login can access Sleepio, but it's no different than This Way Up. And I've been on that website, and you can definitely opt into that.
And is it free, or is it you have to pay?
I think it's free for a while. Then they get you hooked, and then you have to pay, but it's not expensive.
Okay.
But that was really, she said that more effective than medication for sleep. And again, sleep is so important for our overall health. But at the same time, the stress of not sleeping is probably just impacting our health as much. So it's like we do need to change our mindset and, you know, stay away from people who are obsessed with their sleep. You know, how did you sleep? Oh, hang on, I'll check my watch.
Oh no, that would drive me crazy. I couldn't do that.
No, I didn't sleep well.
But it was what I find interesting. Before we come in here, you were talking about the sleep thing, and you said instead when you wake up in the middle of the night, or you're waking up 4 a.m. and you're like, oh my goodness, I've only got 2 hours left to sleep. I need to sleep. What were you saying you should think?
She was saying, oh wow, I've still got 2 hours.
To rest.
Yeah, to rest.
And regardless of whether it's sleeping, I'm resting my body.
I still got 2 hours of rest before my day starts, and to just, you know, change the mindset about those 2 hours. And another thing she said, which I remember, was that there are certain apps, you know, like Calms, I think, and a few different apps that can help, that you can put on a podcast to try and get you back to sleep.
Someone's like, George Clooney's like, no, you can fall asleep.
Yeah, that was one option. But the one I remember that I thought was quite funny was that there's an app called Nothing Really Happens, and they tell stories. Nothing ever happens. It just goes on, and then you end up like,
you're so bored.
You're so bored with the story. Yeah, she said nothing stimulating, so just stick on something. You know,
that's interesting, because I listen to podcasts that are maybe monotone podcasts, and they speak in the same tone, and I find listen to podcasts where men are speaking and they're just do. I find that will put me to sleep. But if I'm listening to female voices, that perks me up.
Potentially. Yeah. And also I do notice if I do that I never remember the podcast.
Oh no.
So I have to listen again so that I must have fallen asleep. It's almost reassuring to go back in and say, oh, I've heard none of this. Actually, I was asleep. Yeah. I must have been dreaming that I was awake.
Okay, that's so kind of sleeping is so good.
And just rest. Yeah, you know, and cumulative. If you are someone who catches up at the weekend, she did say, don't lie in. I didn't like that. Oh. She said, like, as some of the kind of overall rules of good sleep.
Okay.
She said, and like, I find that's usually not a problem for people with small kids anyway, but you know, you're kind of lying till 11 or 12 on a Sunday, that it's throwing your rhythm, your circadian rhythm for the rest of the week, that it is important that your body knows what's happening and to have the same kind of routine and ritual at night time as well. And of course the screens, you know, not to be on the screens when you're trying to nod off to sleep. So yeah, nothing else kind of mind-blowing, but just the few tips about healthy sleep.
I know, I like that different mindset, because instead of waking up at 4 and going, shit, I've a couple of hours left only, and you're beating yourself up, you're like,
and then you won't get back to sleep. Oh, the other thing she said was to respect the sleep of the person in the bed, the other person. So like, you know, if they're, you know, respect the fact that they should respect your sleep. So if you do go off to sleep and you're snoring or they're snoring, you know, that, you know, you need to respect the fact that they need to sleep as well. So I think what she was implying was not to give them a
hard
dig in the back. Maybe a gentle roll.
I just try and roll them over on their side. Just I find
but she said, like, and I suppose it is infuriating if someone wakes you to tell you that they're awake. You know, so that she didn't.
If the camera zoomed in on me now, I'd be looking very guilty. Okay,
she didn't recommend that.
Damn it. I'd love to talk to you about bone health.
Yeah,
because even just the osteoporosis side, and how we know that the estrogen levels drop and can cause that decrease in bone density, and should women be going on HRT then to prevent osteoporosis if, say, their mother has osteoporosis, or if they're worried about their bone health for their future?
And again, I suppose no more than like one rolls into the other, because we talked about muscle and the importance of that, and the important, like when you're doing your strength training, you're not just working on muscle, but you're working on your bone as well, because every time you pull on your tendons, it's like strengthening and changing the integrity of your bone. So they're all, none of them are disconnected. But if you, like, I suppose the question that came up, and we had a really good talk in September by Nicola Ambrose, who's a consultant in St. James's, and she was saying that, there's more and more demand for doing a DEXA scan in women in their 40s, saying, I'd like a DEXA scan to check my bones. If you have a high risk of osteoporosis for any particular reason, there can be several reasons. And I suppose if you have family members, it seems to run in your family. Now, if your mother had no HRT and early menopause, there's other reasons why she may have had osteoporosis. So if she had another risk, but if there's a family history of osteoporosis, or you've had a consistently low BMI, or periods in your 20s or 30s where you've had no period for many years for any reason, if you've had a previous eating disorder.
Can I ask, do women who've had lots of babies, does that affect?
Prolonged breastfeeding can impact on bone health.
Okay.
And can be a risk factor, but a temporary risk factor until the breastfeeding stops.
Okay.
Yeah.
And then it rectifies.
So I think a DEXA scan directly after prolonged breastfeeding, I wouldn't be jumping onto treatment as much as watching what happens. Okay. And like considering each individual patient, that kind of way, if there's other risk factors. If you've been on steroids for years, for any other reason that you have, like say Crohn's disease or something, you've been treated for many years on steroids, these can all impact your bone health. Then you may need a DEXA scan. Mm-hmm. But what we do is we calculate a FRAX risk, like a risk of a 10-year fracture or a severe osteoporotic fracture. And we look and see if you would kind of benefit from a bone scan at that age. So there's certainly what I would say, Laura, is if your bones are low in bone density because you've lost estrogen, then putting estrogen back in is going to improve the bone density. But if you've had normal estrogen levels and you have another risk factor, then maybe replacing or topping up estrogen on top of a cycling woman in perimenopause may not impact bone health. Does that make sense?
Yeah.
If there's another risk factor, then we look at removing that risk factor, such as smoking or inactivity.
Actually, it is interesting how much smoking impacts bone health, isn't it?
Absolutely, yeah.
And you wouldn't even think it. You'd be like, how does this affect it? But it does.
Yeah, and I wonder, does vaping? We'll have to presume it does. But yeah, so like it's looking at all the risk factors and having the conversation and seeing what are the changeable risk factors and what are the inherited ones that you can do nothing about. But certainly if there were also symptoms of menopause, then I would be definitely thinking that HRT would be first line for treatment of the osteoporosis, without a doubt. Osteopenia, depending on what other symptoms are there at the time.
Because osteopenia is before osteoporosis. So
yeah, not in the normal range, but not quite in the osteoporotic range.
Okay.
And then you can vary on just about to become osteoporotic versus just out of the normal range, that kind of way. But it's a matter of keeping an eye on things and learning what you can do for your own bone health.
And can I ask you as well then, for women that would be on HRT and they're for their bone density, and then they go off it because, the 5 years or the 10 years and they're supposed to go off it. And I know that you're very knowledgeable when it comes to menopause, but there would be doctors out there, and there are amazing doctors and GPs, but they're just not quite there when it comes to the menopause care. So women are taken off it. Does their bone density then just fall off a cliff? Is that something to be worried about? Has there studies been done on that?
So I don't know it directly with HRT.
Okay.
There are different osteoporosis medications that you absolutely cannot just come off. The main one being denosumab or Prolia. And this was discussed in Melbourne at length because it has become a problem. That you really, the dilemma being that we don't really know what happens after 10 years on denosumab. So younger women who are started on it are getting to that 10-year and maybe choosing to stop it, and that's detrimental because immediately
they have a go on a bisphosphonate as an adjunct
or HRT. Yeah, and the other thing that I don't know if it's a problem in Ireland, I certainly haven't witnessed it, but a couple of the Australian doctors alluded to the dentists stopping the bisphosphonate or the Prolia and say, no, you'll be okay without it if the patient needs dental treatment, and then it doesn't get restarted. And there was one of the doctors put up a case of a woman who had presented with two fractures in her back from her dentist having stopped her bone medication to do an implant. and she hadn't restarted it. It was only like 7 or 9 months beyond when she should have had it.
Yeah.
It was very quick.
It can significantly drop. And I know that there was some cases during COVID where people missed their appointment for their Prolia.
Yes.
And they then didn't take it, forgot to take it, couldn't get it.
Yeah.
And the bone density decreased, or they had a fracture.
So you should have it every 6 months.
Yeah.
And I think in Prolia and COVID, we stretched it out to 9 max, and then they had to come in. You know, the things we did in COVID, like it was a 2-second injection.
I know.
But yeah, HRT, no, it may not fall off a cliff, and the benefits may be maintained. The benefits of bisphosphonates will be maintained for up to 5 years. I don't think it's quite as long for HRT. So we'd want to be checking again.
Yeah.
So I would say if you were stopping and choosing to stop, first of all, we'd talk about why. But if you do, then we would check a DEXA maybe a year to 2 years after that and see if you're maintaining your bone health. We know you won't maintain it with Prolia, but you should maintain it for longer with HRT and for a prolonged amount of time with your bisphosphonate.
Okay.
But it's definitely something not to do on your own.
No, absolutely. Yes, you need to check in with your doc about it.
And as we say, there are alternative solutions to treating your menopausal symptoms. But remember that if you take the non-hormonal choices, it won't benefit your bone in the same way. So just to think about bone, if your patient is choosing a non-hormonal option, to just remember that their bone health will decrease, or that their bone density will decrease with time, and you need to keep an eye on that.
Okay. You talked about ways that women can mind themselves in midlife for this longevity, and you know, can our lifespan match our health span, or vice versa?
Yeah.
What are the other key tools that you tell people when they come into you for a consultation that they can be doing?
Well, one you just nailed, to mind yourself, self-compassion, and a bit of like looking after yourself, and it's okay to have some time to yourself, because I feel that midlife is that time where you've teenagers,
some women have toddlers.
You might have toddlers.
Oh,
and there's really no time, whether there's time for yourself or not, there's guilt of taking it, you know. But if you don't look after your midlife health, your future health is going to suffer. So like sometimes I've started to prescribe exercise and prescribe movement, to write it down, because it gives the message that it's just as important as the prescription for the HRT or for the bone medication to go to the chemist and pick it up, but that this is actually the equivalent. So why are we trying to, pardon the pun, put a patch on it? But you know that this movement will fix the problem, will prevent the problem. So it's just as important, and it's just as important to prioritize yourself. So I do think that's one, because self-care and empathy for yourself will also help stress prevention. And we can't diminish the impact that stress has on your current and future health, on your blood pressure, on your sleep, you know. So stress management is really important. So sometimes women don't have time to deal with their stress, you know, but it's like a chicken and the egg thing. So I often encourage, you know, having someone to talk to or something to do. And it can be like a good friend to go for a walk with. And that's why the walking is so important, really, isn't it? It's good for your head. It's good for your mental health. So that's one thing. So we touched on bone health, moving, like diet and lifestyle, so important, but not just focusing on getting thin, getting strong.
Actually the opposite of focusing on getting thin.
Yeah.
Like, get strong.
What I often say to women in my room is like, the worst thing you could do now is go on a fad diet and lose weight quickly, because all you lose is your muscle. So now we've got to hold on to the muscle, and yes, work on the fat slowly, but if you're losing fat, you've got to be building muscle. So don't lose weight without movement. You've got to put in the exercise.
Women beat themselves up about the weight thing though, Claire, like they do. Totally. Like all I hear from women is, maybe I had a belly, but now it's twice as big as it was, or I never had a belly and I can't get rid of this. And they're trying everything, be it calorie deficit, which I wouldn't agree with anyone doing, because it's unsustainable, and you're just going to get more irritable and lose that muscle mass like you're talking about. And then over exercising, and then beating themselves up that they can't wear the clothes that they used to.
It's so connected to how we feel about ourselves. And I wish we could change the mindset, that it's very much cultural, isn't it, that we long for the wedding weight or the slim profile. But like naturally, like if you look back on like generations or thousands of years ago, I do think body distribution naturally changes. And there must be a reason that our body holds on to fat. And like maybe like because of lifestyle now, maybe excess fat. But in general, our body doesn't want to lose as much fat as it would have in years before. And that's probably because our bones are asking for fat and our bones are asking for muscle, you know, in order to maintain our strength, our power and our brain health.
Yeah.
So that if we could just focus, I'd love to kind of even in society, try and focus on embracing.
Yeah, I'm saying,
you know,
go a bit easier on yourself.
Yeah.
Buy the clothes that are that bit bigger. Go for the extra clothes size.
And we are a generation that have grown up with mothers on Unislim and Weight Watchers always like and
Jane
thinking
Fonda.
that, yeah, totally. And oh, you look great, you've lost weight. You know, so, you know, like I suppose, where do we start to try and change that mindset? I always think we start younger.
Yeah, absolutely. Like I don't really ever hear men complaining about the fact that they've put on a bit of weight in their midlife.
No, or complaining that women have.
No,
they don't notice. I think they don't.
No.
Yeah.
So it's about changing our mindset, being kinder to ourselves, accepting our new body. And I think as long as we're eating as healthily as we can, while also enjoying the nice things in life too. Like who doesn't love an Indian
everything
takeaway?
in moderation. Yeah.
And if you're healthy 80-90% of the time, and then you let the wheels come off at the weekend and enjoy that takeaway, but you're back on the wagon then, you know, on the Monday.
I think the mobility and the movement and the exercise drives that. And it drives the serotonin. Like, so if you feel strong and you feel good and you've moved today, then of course you'll enjoy whatever you choose to eat for dinner.
Yeah.
And I think just like, I think routine helps as well, not eating and doing the same thing all day every day, but just I suppose motivation drops though, you know, it's the chicken and the egg. So sometimes I do find that women come in and they have been exercising, they know what to do and the mojo's gone, you know, the pep and the step is gone. So sometimes when we do start HRT, that's what comes back. So HRT does not cause weight loss.
No.
And we don't want it to.
And sometimes women can find actually when they go in HRT initially, they feel that they put on a bit of weight, but a lot of that's fluid retention and it can...
Possibly, and I just, usually that settles out.
Yeah, it does settle out within, I think it can be about 12 weeks, but I know in general, you almost need to push through that. So don't...
Sometimes progesterone driven too.
Yeah. Yeah.
So yeah, you need to kind of reassure and maybe manage expectations there. But some women just feel fantastic because they feel like they want to do it again. And they feel better about themselves. I see it low. I really do at the 12-week. I often look forward to that kind of 12-week follow-up because more often than not, they feel much better about themselves. And sometimes they just, like, I feel back to myself or I feel me again.
Yeah. And that's all they want. Feel like themselves again.
Yeah.
Not feel like they did
when they were... Which means they probably did love themselves.
Yeah, of course. And they should.
Yeah, exactly.
And what about the mood changes that can happen as well? Like, what would you recommend to women that just feel like... It's not even that it's a lack of energy, it's just that baseline dullness.
Yeah, and even women who have suffered depression before will say, I don't feel depressed, it's flat. It's like someone's let the air out of my tires. And that is a bit of motivation. But I do find, Laura, a lot of that is because they don't like how they look. We can't take it away from that.
Yeah.
That they're like, they want to look differently or, you know, that they feel that other people are noticing that they look different. So I do think that mindset matters a lot. So can't dismiss the benefit of a bit of therapy or a really supportive friend, or to just kind of try to get them to work through like the appreciating the body that they have and the fact that it works and the fact that it's strong and healthy and that we have so much power to keep it that way, you know, and that the power lies with us, which I think is liberating, you know.
Absolutely is.
You know, that we don't need tablets to stay healthy.
Yeah. When I was back at you are obviously one of the, is it called chairperson of the Menopause Society of Ireland? Co-chairperson, yourself and Quiva, isn't it?
Yeah.
But I remember, what I find interesting was, because I was really interested in the talk about mood and depression and the lady, and I was a little bit surprised because the lady that got up and she was talking and she was saying that there isn't an awful lot of evidence about HRT benefiting people, particularly if they've already had mood disorders in their younger years.
Yeah. So what I think there is that if the change has not been driven by a change in your hormones, then it's not going to respond to a leveling off of your hormones.
Yeah.
But even people who have suffered from depression for years or from bipolar disease will still go through menopause.
Yeah.
So their hormones will still dysregulate, so that it might bring back to a baseline. And I find that with many specialists, actually, you know, rheumatologists as well, that they often now are encouraging of HRT because it kind of clarifies things for them, because there's such a crossover of symptomatology, and as well, presumably for psychiatry, you know, if things escalate or the mood lowers where it's been stable for years, it's like, do we need to increase or change the medication here, or has something different changed?
Yeah.
So maybe then reintroducing or introducing HRT at that stage can have huge benefits, and not just mood-wise, but it might stabilise what's changed, so that the psychiatrist can then see if the mood has genuinely changed, or if the mood disorder has impacted the change in any way.
Yeah, so I think that what's really important for women in that situation, if they have had anxiety in the past or depression in the past, and then it flares in midlife, or they find that their symptoms are returning when they've been stable for years, that they definitely need to go and have that conversation with someone.
Yeah, and the reality is, and I think this is what they alluded to as well, is that your life experiences by the time you get to perimenopause can really influence how you cope or how you interpret your symptoms. So the same symptom might be very traumatic for one woman, and another woman might be saying, look, well, I'm fine with it. But, you know, we don't know what journey that woman has had to it and what support she has at home in order to get it. So there could be an undiagnosed depression that's been there for years as well. You know, so not every depressive episode will respond to HRT, and not every depressive episode will respond to antidepressives. But there's so much outside of that box that influences when you're sitting in that chair and suffering from your symptoms. And I often ask as well in midlife about postnatal depression. So there's a real sign, you know, and sometimes a woman won't have been treated or diagnosed with postnatal depression, but I'll say, how were things with the baby, you know, and how were things afterwards? Did you really enjoy it? Or if you look back now, was it a struggle? And sometimes if she has suffered from postnatal depression or a low mood at that time, that it could indicate more likely to develop PMS symptoms coming into perimenopause, and more likely to have mood changes in perimenopause. So there's there's a kind of connection there.
It's such a nuanced conversation, isn't it? And that's why menopause and midlife care isn't just...
And you know what else is so important in future health and midlife care that we didn't touch on yet, but your reproductive history. So if you've ever been pregnant, did you have hypertension in pregnancy? Did you have a preterm baby? Did you have low, any kind of complications in pregnancy or gestational diabetes? They're all red flags for future cardiovascular problems. Endometriosis, polycystic ovaries, they should be all part of our medical history. And traditionally they probably weren't when we were learning how to take a medical history, but now they're part of my kind of basic history when I'm meeting a woman around perimenopause, because that will signify to me, if she tells me she had blood pressure in pregnancy and then her blood pressure's high in the room, she's definitely not getting out.
Okay.
It's a real red flag that, and I think we should be telling women in the postnatal period, mind you, it's very traumatic, you're going home with your baby and everything, saying, no, you're going to have blood pressure when you're older. But just an indication that, and with women with polycystic ovaries, that they have a higher risk of hypertension and they have a higher risk of developing diabetes. So they should be watching for that and maybe being mindful that might happen in the future.
Okay.
Yeah. They say that pregnancy is like a stress test.
Guys, if you don't have enough going on.
If you've survived, but on the flip side, if you've survived 3 pregnancies, then you must be pretty strong.
Yeah, I suppose that's a good way of looking at it, isn't it?
Yeah, it's easier. It's easier to run on a treadmill.
This is very true. Can I ask you, for the future of menopausal care in Ireland, where do you see that going? Because I know currently there isn't a standardisation of care. So, you might have Mary down the road that's going to their GP and they're wonderful, and you have Anne next door to her, she goes to a different GP, and they're just not quite there yet with menopause care. Is there a huge uptake in GPs taking on the extra CPD and all of the rest, or is it going in the direction that we wanted to go in?
I think that GPs are drowning. So there's huge interest. And first of all, women are talking and asking, and that's super, because I don't think this is a phase. I think this is here to stay, and that we've recognised and we're acknowledging the importance of menopause and midlife health, and that it is something that 50% of us will go through. We won't all suffer through, we won't use that word, but that we will all go through it, and we need to be armed with knowledge and options and choices. And I suppose the little bit that we're doing is, like, when we established the Menopause Society of Ireland, is to try and support the education of healthcare professionals, and not just GPs, but like all specialists, so that we're all on the same page and we're communicating. Because I think like medicine only works well if everybody's on the same, singing off the same hymn sheet, or actually talking to each other. So that kind of communicating and learning from each other. So we want to talk to the cardiologists, because we want to let them know what we know, but we also want to know what we don't know and what they know, so kind of organising educational events and supporting GPs and providing resources. That's what the aim is in what we're trying to achieve there. So that's just a small part of it.
Well, I think just from even the amount of people that were at that first day.
I know, it was great,
wonderful.
Wasn't it?
It was
but
such a great
what I
feeling.
think, or we need to look at medical students.
Yeah.
And we need to look at GP trainees. And certainly the ICGP is working on educating GP trainees and increasing the knowledge that when they come out. But like, if we go back to medical school, that means every specialist, the orthopedic surgeon, like everybody will have learned more about menopause. So, it starts young.
It does. But even when I was doing my pharmacy degree, like that's a 5-year course of a 40-hour lecture and lab week. We got 1 hour on HRT.
I don't remember 1 hour.
I know.
Yeah, I don't think.
So I think if we're starting with the students and they're aware of it, rather than everyone working in silos, because you'll have your orthopedic surgeon that might be dealing with a frozen shoulder, but that isn't joining the dots.
And also not just that there's a lecture on menopause, but that it comes into each lecture.
Yeah.
Because it's part of every system, so that it's mentioned and it's relevant, no matter what module you're working on, that it's mentioned in that way. And not in a negative way, but just like the impact of it, and that the terms perimenopausal and postmenopausal just become normal terms in every specialty.
Yeah.
So I always think, go back and start at the beginning, and that's how we're going to change things. But things are moving.
They are. It's good to see.
We're in a better place than we were.
We absolutely are. Claire, is there anything else that you'd like to say to women out there, or their partners, if their partners are listening as well, or their family members, about this area?
Yeah, I think partners sometimes don't know what to say or what to do.
God love them. For sure, if the women don't know what's going on with themselves, how do their partners know? And I always say that we need to go easy on them too, and educate them with us.
The patients that I have that are married to women, there's mutual support.
They're so good. I know.
They understand each other.
They understand. Yeah. Although I don't know, 2 perimenopausal and menopausal women in the house.
Sometimes I've had a few that there's been like maybe a 10-year gap, and one is like extremely supportive of, I suppose the younger one benefits.
100%, because I don't know if there's 2 together in the one family at the same time, I'd say that's fireworks.
But is it, or is there compassion there? And like sisters are supportive, and family history is really important, like, because there definitely is a pattern. But at least we're still talking. But for partners to just maybe understand, so I think it's really important to listen and explore as well. And it doesn't have to be always the sympathy vote, oh God, poor you, but just to know when to speak and when not, what to say and what not to say. We could do like, a little kind of drop a pod on that.
We'll do another one on that, what to say and what not to say.
Yeah, but like, and sometimes if your partner is really struggling, that it might be okay or understandable to suggest going to a consultation with her, to know and understand what she's going through. And sometimes in other specialty areas like endometriosis or PCOS, I find that very helpful, because the partners are trying to support, but maybe not sure how to support in some ways. But taking the kids is great.
100%. Allowing that lie-in that we're not supposed to have now, so you say.
Yeah, but we can do what we want.
We can do the book. It's our choice. Exactly.
Read the book, listen to the podcast. Who knows what's happening?
Exactly. Claire, before we wrap up, I'd love to ask you what advice you give to young people today.
Oh, okay. Well, first of all, I think we need to change the attitude to speaking about women's health. And, I still think maybe it's a bit secretive in some ways, and that we're hiding it away, that it's okay to talk about periods, that the language needs to be all normal. Yes, there can be it can be intimate or private, but that it is okay for young girls to talk about their periods, to ask the questions. We need to talk about menopause in primary school and secondary school. Yeah, and we need to look at that too. The language needs to be normalised, and the teachers need support. I think teachers would love to see that happening, because a lot of them are going through it at the same time, and that's a mutual understanding of understanding why maybe someone's not in good form. That it needs to start even at that young age. So it's okay to talk. It's okay to ask questions.
And look, what is the average age of a teacher? It could be teachers that are going through perimenopause and menopause and not in a good way with it. And it's important that they get that support too.
And then home to a stressful environment as well. I think that they would be very much in support of bringing an educational module into school. It could be very simple in primary school, but just even getting used to the language. And the word menopause doesn't appear anywhere.
No.
Yeah, and there's definitely more to discuss, and I think more compassion for young boys and girls in secondary if they knew what was happening at home and they understood.
Yeah.
Yeah.
And what's the meaning of life?
Oh. To me, not work, but family, communication, community, that we go to work and I get so much out of my job and out of supporting people, but it's everything that happens outside of that that I think is important. But supporting each other, talking and communicating, I think is so important.
Absolutely is. Clare, it has been a pleasure to have you on. Thank you so much.
Thank you, Laura.